Good afternoon. Hi, so I'm Susie Novus Durie. Many of you know me from my movies. No, but some of you are probably new to the world of myeloma. How many people are coming to a seminar for the first time? How many people? Okay. Okay. So you're not going to believe this when I say it. You'll say, oh, she can't possibly be true. You're going to learn a lot. You're going to meet a lot of really great people. And you're going to have fun. We mix it all up together. And when you walk out of here, you're going to feel a whole lot better probably than when you walked in. And I think people who've been coming to the seminar for a long time can attest to that. So what I wanted to just briefly talk to you about before we really get started is over the years, we've developed a lot of different publications that cover a whole range of topics. In the beginning, we had one publication because there really wasn't that much going on in multiple myeloma. And now we have 30, 40 some odd publications covering a wide range of symptoms, problems, you name it, and we have a publication for it. But the ones that I think are really most important are the patient handbook. This was our first one. And so anybody who's newly diagnosed or who had one of these, but it's years old now, they're all free, by the way, free. But the patient handbook is really, really a great tool to have in your stack of stuff at home. The other thing, and this is more for caregivers rather than patients, understanding dexamethasone. Yep. In here, it tells you how to duct tape them, sleeping pills, that kind of thing. No, dexamethasone, as you know, it's a very important component of many of the treatment regimens, but the side effects can be really, really hard. So you better understand it, and that way you can manage it better. Another thing is, people are always saying, I get these papers and it has all these numbers and letters on it. What are they? Well, they're your test results, which is very complicated. I think doctors drink a lot and then put that thing together, and we're supposed to understand it. But seriously, understanding your test results is another really good publication for you to look at to see, how you can make sense of it all. And then this is a newer one. It's understanding our immune system. And quite frankly, I do not understand my immune system, but I know that I never get sick, so I think I must be very nice to it. But this is really important too. While you're going through the process, when you're on certain medications or transplant, your immune system is down, and this is a really good booklet to find out how you can keep it boosted up. Years and years and years ago, because the IMF was founded in 1990. I've been doing this since 1990. Okay, don't think about it, Susie. We started this publication called Myeloma Today. How many people get myeloma today? You know what? It's free. So I would suggest you sign up for Myeloma Today. It comes out quarterly. It has a wealth of information on a whole range of topics. And then, something else I wanted to talk to you about is one of my colleagues, Suzanne and Alana. Are they in the room? Suzanne and Alana, you in the room? Okay, these two amazing women, there's Alana in the back of the room. They run member events. How many people here have been to a member event? Raise your hand. Really? Alana, you got to come down here. So member events are held all across the country, and they can be anything from a golf tournament to, a walk in the park to whatever it is that you'd like to do in your normal life, you can turn it into a member event, and they'll tell you how. And they raise hundreds of thousands of dollars every year for member events that goes directly to support myeloma research. And that's why we're getting so much closer to a cure, is because people like you are doing things like this and getting that money in there that we can use to support myeloma research. And you're going to hear a lot about how close we are to a cure. So anybody in here today whose chest is heart's beating out of their chest, calm down. We are so close, you will not believe it. Something that's coming up in Staten Island, which is oh so close to here, but people do things like a comedy night. What's better for the healing and your state of mind than going out and doing something. But these are the type of things that people organize with the help of Suzanne and Alana to get a member event going, and it really does make a world of difference. This one I'm not too sure about, but it sounds like fun because it's called the Flying Pig Marathon. Now, I wasn't sure that pigs could fly, but evidently they can, so I think that all of us should attend this one just to get, see how it's done. So those are just some things that I wanted to brief you on because, as you know, we're a nonprofit, and so much of our money goes to support myeloma research, and you're going to hear Dr. Durie talking to you today and tomorrow rather, about the Black Swan Research Initiative and the I Stop MM. And after all these years of being in myeloma land, I actually see an end in sight, and I'm not kidding you. And that word starts with a C, and it's the cure, and we are so, so close. So anybody who's sitting here today with their heart pounding out of their chest, calm down, we got this, and we are getting there so fast. So that's kind of like a really brief overview, but I want to also just tell you, so people who are attending for the first time, so we have 4 people with microphones around the room. When you have a question, each one of us are taking a particular section. When you have a question, just raise your hand and we'll come and give you the mic. Please don't start from the beginning. Well, I was born in, and then we moved to, and then this happened, and then I got diagnosed, and the next thing you know, it's too long. Get right to the point, because everybody here probably has a question. The room is full. So without further ado, I'm going to ask Dr. Brian Durie to please come up. Dr. Durie.
Oh yeah, we got it right. We got to be the same as the screen. I think we got it. So I'm on the right, he's on the left. Okay, we're good. So I'm Dr. Durie. This is Dr. Hoffman from right here at the Sylvester. We're very, very pleased that he agrees to come for these sessions and try to focus on some of the questions that are most immediately on your mind. The good news that we've had in the last few years is that there are so many new therapies available, but a little bit of the bad news is, like, when do you use them, how do you use them, which combinations are best, and so there have been emerging a lot of questions about when to use these new drugs and how to do the very best job. So we can talk about that, or some question that you've been maybe worried about for many years, and just be aware that for many of the topics, we're going to cover them in quite a bit of detail tomorrow, but nonetheless, we're keen to hear about these questions that you might have today. So you may get 2 perspectives, you may get the same opinion. From working before, there's a lot of similar opinions, but sometimes a little different, so we'll see. Who's going to be first here today?
Do you believe there's a connection between the oral chemotherapy drugs like Revlimid and the prevalence of skin cancers such as the squamous cell carcinomas?
I think it's pretty clear that patients exposed to Revlimid, in that category of medicine, who have also been transplanted and exposed to melphalan, that there is an increased risk of what we call secondary primary malignancies, or SPMs. And within that group, a bunch of them were skin related. So I think there's no question that there is an absolute increase in risk. It's not a tremendous increase. It tends to be certainly dwarfed by the benefits of both transplant and Revlimid. So it's a risk, I think, that's well worth taking, but patients do have to be monitored carefully for those things so they can be picked up early and cured, like most of the squamous cells of the skin can be.
Right. So it's in that 3, 5, 6% range, and obviously right here in Florida there are 2 other risk factors. One is the sun, which is right out here, and also age are 2 big factors for those kind of cancers, but it is definitely increased by a few percentage points by the Revlimid. Okay?
Has to do with chronic fatigue. For the last 2 years, year and a half, my wife has been on steady state and just having her blood checked. But as far as chronic fatigue, is there a relationship about the low blood numbers, particularly the platelets, the red blood cells, and anything to do with carrying the oxygen to the muscles, et cetera, that could be helpful in this fatigue situation?
Yeah, so obviously, chronic fatigue is something that can crop up. It's often linked to treatment. Are you taking like Revlimid or something? Are you taking a maintenance?
He said not for a year and a half.
Not for a year and a half. Yeah. Okay.
Yeah, her red blood cells are just right on the borderline
So-
between the low side, but they're still marginally okay.
Right.
But
So in terms of the blood counts, obviously, as you're understanding, the red cells are the ones that might be the most likely, if they're low, to contribute to some tiredness, and so that can be an aspect. We tend to not use as much of the growth factors, the EPO, which we used to use in the past, to boost that, because that can have some side effects. But it is something that can be a problem, and so if it's not treatment related, it's something that we just try to work as best we can to try to help your activities and try to get beyond it. The low platelets can be a problem, but they don't cause fatigue. Likewise, with the low white cells, we worry about possible infection, but it does not in itself cause, the fatigue. I don't know if you have any magic tips for fatigue.
Yeah, I think that in some ways fatigue is the hardest symptom to address, because it's almost always kind of multifactorial. When the disease is active, that contributes. Many of the treatments contribute. And even when you're off treatment, you've been through active disease, you've been on treatments, it takes a toll on people. But I think, like Dr. Durie referenced, you have to do a pretty comprehensive evaluation to make sure, you're not just blaming the myeloma or related issues. Hormonal changes can impact fatigue, and men sometimes low testosterone we see is something that's a fixable problem. So I think sometimes down mood, depression can kind of get into a feedback loop in terms of energy. So usually we try to kind of take a broad range of potential diagnoses and work through them one at a time. In your case, if the disease is quiet and you're off treatment, that kind of removes those two very common elements that I'm sure many in this room would say contribute to their fatigue.
Right. So, as Dr. Hoffman says, rule out other things like low thyroid, and make sure you get a full medical checkup to make sure nothing else is going on and maybe contributing. Okay.
Hello. Thank you so much for doing this. Sometimes watching all the videos that you guys do just brings up questions, and there's no one to ask. So this was a patient power video, and Dr. Van Ries said, there are known subtypes of patients who may not achieve MRD negative, but we know they do very well. So my question is, do we know, what are these subtypes, and what is the testing being used in the clinic to identify these?
Yeah.
So, I mean, I could take a stab at it. I think, or
Yeah, go ahead. No.
So
Take a stab.
let's take a stab. So you're asking, I think, you're getting into what's a very critical issue. You have a whole room of people with one disease, but it acts so differently. And we have, excellent predictors like the FISH testing, responses, how low do you go, do you get MRD negative, different subtypes, et cetera, right? And all these things kind of can be lumped into these algorithms, and we try to prognosticate. But with all of that, we just get very general approximations of how people are going to do. And like you said, sometimes it's the person who doesn't even get into remission, who has a very durable disease control, and someone else is in remission next room, and they're MRD negative, or certainly a complete remission, and they relapse sooner. So I think, unfortunately, all we can do is categorize people to the levels that we're able, speak very generally about prognosis, and then remain really, really vigilant about early signs of recurrence so that we can, intervene early.
Yeah, it's a very, very individual thing. So I grew up in Scotland, and when we would make hospital rounds there's the eyeball test, and so when you go to the hospital and then you kick the foot of the bed and the patient doesn't perk up, this is not good. You need to individualize your patient care and work through each of these different things that Dr. Hoffman's mentioning. So is it a high-risk case where, MRD might be more important to try to achieve. It is very personal.
Okay, other question? Next question?
What is your experience with putting Darzalex with Pomalyst and Dex?
Okay, well, this is a very good regimen. It's actually one of the few of those novel combination regimens that is approved by the FDA, and so it has several advantages. Number one, it works, and number two, it's approved so it can get reimbursed. And so when Darzalex, this is the monoclonal antibody against CD38. So obviously this is one of the more exciting new treatments for relapse and early relapse and even probably a little bit later relapse, I'm suspecting. It was approved as a single agent and then approved in combination with Revlimid and also pomalidomide. And so this is really an excellent combination, which is well tolerated and is one that I think is a good one to recommend. I don't know, do you have a particular question about it?
ANC count dropped. ANC whites.
Right, so the key thing in that regimen, since you're combining it with the Darzalex, is the dose of the pomalidomide. And so it may be that the dose of the pomalidomide needs to be reduced.
1 milligram. We're at 1 milligram.
Aha.
Or with the 1.
Okay, maybe reduce the number of days that you're taking it. I mean, I think that you do need to tweak these regimens to get them to be working and then to be tolerable. I don't know what, what's your experience been with this regimen?
No, it's fantastic. I mean, daratumumab combined with lenalidomide or pomalidomide are really amazingly good regimens, and a significant group of patients that do well do extremely well and really get even MRD negative. And so I would just say one thing about the white count. You know, we all look at the white count, we look at the neutrophils, but there is a group of patients, you're already on a lower dose of Pomalyst, which is reasonable. There's a group of patients that hover on the low side of the white count but are not getting infected and are generally doing well. Sometimes we can give some preventative antibiotics. I think, I worry sometimes we pull away from good therapies because of the theoretical concern of the counts, and I think sometimes it's okay to try to plow through, get a few cycles in, get the myeloma to better control, and then usually see the counts do get a little bit better, especially if you're not dealing with repetitive infections. So it's a balancing act that you and your doctor have to kind of partner
Right.
to make those
Yeah,
decisions.
so maybe just not back off too soon. I fully agree. Yeah. Okay.
Thank you, doctor. I was wondering, 17p deletion, are there classifications with that? I've been
Are
reading.
there translocations related to that?
Yeah, are there different classifications of P17? Degrees.
Oh, classifications? Okay, so there are many of these different chromosome abnormalities, which can get to be a bit confusing. So the 17p minus is one of them, which it goes into this group that we call high risk. And these are difficult terminologies because what that means is that frequently the myeloma will respond very, very nicely to therapy, but we know historically that the remission could be shorter than the average. And so it's a type of situation where the disease has a shorter remission, and it may be more difficult to retreat at the point of relapse. But you can get it by itself, but it can also be combined with other kinds of chromosome abnormalities which can impact it. So this is the sort of thing that when you get those test results back from the doctor and he gets what's the fish report, it's really important to say, look, could you sit down and go through this with me? Because there are some little details to that could impact it in your case. So sometimes it could have something called trisomies, where in addition to that, there could be some extra chromosomes in there, which can be a good thing, and so maybe balance it out a little bit. And so there are all kinds of different combinations that would put it into a high risk an intermediate, which is a 414, where there's a 414 translocation, or these trisomies alone, where you have these combinations of 3 chromosomes, which tends to be kind of a good thing. And so I don't know how much trouble you have explaining all of that to individual patients. Sometimes it can be quite tricky.
Yeah, no, I mean, of course, I agree. The one thing I also try to emphasize with patients is, when you're diagnosed and you're looking at these numbers, and then you hear high risk, it's hard to kind of take in. And what I try to explain to patients is, if you treated everybody exactly the same way, those that have the higher risk features would have a harder time as a group. But that's not a foregone conclusion that anyone's going to do poorly. It just tells us that we need to be more proactive with our treatments to achieve the type of results that are acceptable. And with the 17Ps, that might mean stronger inductions. It certainly means more comprehensive maintenance programs. And I always try to make that point that this is not reading tea leaves to predict bad things. This is showing us how the myeloma is likely to act so that we can act on our end appropriately.
Right, right. It's a group thing, and so when we show, as we will be a lot tomorrow, show these 2 curves, where there's one which is the 17P, which tends to be lower than the one without the 17P. When you look over to the right, you'll see that both of the curves do move over to the right. So it's just an individual thing where percentage-wise there are patients within that 17P minus that will do more poorly, but not necessarily across the board.
Thank you. This question is from one of our support group members who couldn't be here, and it relates to pain. And she wants to know if you have an opinion or if you're aware of any contraindications to like electrode stimulating machines or anything like that for pain, where there's bone involvement.
Yeah. I don't know, I mean, there's been some cautions about that. I don't know there's strong data, though.
Yeah, I don't think there's any formal contraindications. Some patients achieve some improvement with like a TENS device or, that kind of thing. And I don't, things like acupuncture, I kind of put those in a category of if they help, I'm okay with them. And if not, don't stick with them for too long. Everything should be done by reputable people and not some sort of back room somewhere. But I think I think we get questions about that a lot. Medical marijuana is becoming a very popular topic as it relates to pain and other symptoms. And again, I view those types of devices as okay to try. I don't think they offer profound benefit, but I've had a few anecdotally that have benefited.
Yeah, so I think it's safe. It comes up a lot. There's been some questionable reporting on that, but I think it's fine. But moderation in all things.
Kelly?
Hi.
Okay?
I have another question on the white blood cells. I was on 10 mil. I've had transplant. I'm in remission. I'm on. I was on 10 milligrams of Revlimid, and my white blood cells dropped. So I'm on 5,
Right.
and I'm still neutropenic. So my question is, they don't want to give me a injection. So what is there a reason? I don't know. I'm a patient of Dr. Holarski's in Texas, so I did it over the phone, so I really didn't get a chance to ask him that question.
So if I think I'm understanding is that, so you were on 10 milligrams of Revlimid and your white count dropped low, and so then they put you on 5,
Right.
and your white count's still a bit on the low side,
Right.
but they decided not to give you any injections to boost the white
Right.
cells, probably, right?
Right.
And
I didn't want that done.
right.
And I
And
just
that's
wondered
probably
what
because,
the
just
reason was.
just as you were saying, that's probably because you have not had any problems with infection, right?
I
Or
did. I had a UTI, but my blood cultures were negative, so it was related to that.
Right. Yeah, so I think that, we don't like to use these boosters to boost the white cell count unless it's really a more significant episode of infection, so we don't try to use that casually.
Well, I'm glad you explained that, because you hear some of the little, on the internet, the people, all the talks, they go to their doctor and they get that shot, and I got the impression it was not a good thing to do.
Right. So I don't use it that much.
No. I think Neupogen, those types of shots, she says Neupogen are helpful for infected people or are used in some very aggressive chemotherapies as a preventative, but in this type of kind of more chronic setting, they really haven't been shown to be valuable to be on them regularly. This is a very common problem where over time, after many treatments, Revlimid doses kind of get tapered down a little bit. There's a dose even below 5 sometimes that can be used. Sometimes we'll come off of Revlimid and use, Velcade maintenance if it's really a major issue. But I have a whole host of patients who have borderline low white counts on lower doses of Revlimid where the Revlimid's working great and you don't want to kind of shake things up from a myeloma perspective. And an occasional UTI is okay, but if you're avoiding more serious infections, again, I think it's okay with close attention to try to kind of go month by month and stick with it. Sometimes, again, you can go from 5 to 2.5. You can go 5, 2 weeks on, 2 weeks off. You can get a little creative at the lower levels.
Yeah, because taking these shots to stimulate the white cells, that's not trivial, it's expensive, and it has side effects too. And so it's not something you want to get into relying on. So it's better to maybe talk to the doctor about 5 milligrams. Maybe you could take it for 2 weeks out of the month instead of 3 weeks or something like that.
Okay, our next question's over here, but before I turn it over to this lady,
Okay.
I just want to remind people, if you have a question, don't go to the internet. Call our toll-free hotline because they are trained. They actually know what they're talking about. And Dr. Durie is right down the hall. And so if you stump them with a question, they'll run down the hall and ask Dr. Durie.
I
And it's
could call
free
Dr. Hoffman on the phone
from
and ask
trained people. Go to the internet. No. Buy a pair of shoes on the internet. Don't buy your life on the internet. Okay, here's the next question right here.
All right.
Yes, have you, or do you know of any correlation between taking Revlimid and short-term memory loss?
I can't remember that. No. That's certainly not a typical type side effect.
No.
I think as far as we can remember, no. But in all seriousness, there are some issues with underlying neurologic diseases where you could have some cautions. For example, if you happen to have Parkinson's disease or maybe something like multiple sclerosis or something like that, I think you do need to have some degree of caution about maybe worsening of some neurologic thing that may be pre-existing, but not with the drug in itself. Okay.
Alana?
For those of us who have had myeloma for a while, the first RVD treatment followed by transplant has been highly successful for many people I know. I call them my myeloma mates. And then when people hit relapse, we're very disappointed by the lack of predictability, how many experiments are done on people. I just lost another myeloma mate on Monday, and it's hard not to believe that one treatment after another, making her sicker and sicker, actually did not help her. I just felt like too much risk, not lowering doses. So, this quick relapse to refractory, a lot of suffering, and then I have not seen people survive very long. And so I'm coming to a choice point, and I keep wondering about Darzalex, which really did not help people, and they suffered. The trial that confirmed that Darzalex, Revlimid, and Dex has such a good result, a lot of those people were Revlimid naive and hadn't been on continuous Revlimid maintenance the way a lot of us now are. So I'm just wondering what you say about Darzalex for people who are not Revlimid naive, given the population that was in that study.
Right. So first let me say it is disappointing to hear your comments there. I think that the first reaction that I have is that in this early relapse setting where you're coming off of, VRD and a transplant, I think that as doctors, we maybe need to be a little bit more decisive in the sense that before jumping into experimental therapy, we have some pretty strong recommendations that we can make that can work well.
I obviously didn't state myself well. It is an early relapse, but they had long remissions,
Right.
like 4 or 5 year remissions.
Sorry, let me a relapse without a lot of previous therapy. So what we would say like a first relapse, it could be long, right? So a patient who has just had the VRD and the transplant, like you said, and the remission might have been quite long. I mean, that makes it even more powerful that we should be able to provide some good, strong advice. And so the first point I wanted to make is that there have been a lot of trials in this early relapse situation, but we can make some strong recommendations of things that should work well. And so, you know, even going back to VRD or another type of proteasome inhibitor Revlimid combination, it could be even ixazomib RD or Kyprolis RD. If it's worked well and given a long remission, we should not be ignoring some of these options that we know could work well. I have heard, and I'll be interested in what you have to say about this, is perhaps a little bit more mixed reaction about the Darzalex Rev-Dex in this sort of a 1 to 3 relapse setting. We've been, as doctors, pretty optimistic about that, and it's highly recommended, but maybe not 100%, you know.
Yeah, I would say, I mean, there's a couple things within your comments that I think are important. You know, I'll make this one point, we're all swayed, when we see something in small numbers, we're swayed by the outcomes a lot, and that might mean a friend, and that might mean someone that we know. That might mean you're a doctor in general practice and see only a handful of myeloma cases over a long time. You know, one bad outcome, one lack of response tends to color the way we feel about things. But I think when you look at things on a larger scale, I think everyone in the room should know that most people on their first recurrence are going to get really meaningful benefit from treatment. If not choice A, then choice B. And the vast majority of those will tolerate those treatments well, without hair loss, without throwing up, able to work. And so this is a time, and there are some unfortunate that it's a real struggle to get them back under control. We certainly see those. And we have to, you know, appreciate that we haven't solved this whole disease and that there are many that remain very needy. For every 10+ year remission, there's someone who struggles in the first year or two. Related to the Darzalex, certainly someone who's on Revlimid, is relapsing on Revlimid, can get a lot of benefit from adding Darzalex. There's even some data that those that have failed Darzalex and Revlimid separately may get some benefits when you put them together. But on the doctor side, we're cognizant of that, and sometimes someone who's relapsing on Revlimid and you really want to use Darzalex, maybe the choice is to up Revlimid to Pomalyst. This way you're going to kind of a better, more a higher generation within that. Or even there's data with Darzalex and Velcade. So if you responded to Velcade back in the day and you've relapsed on Revlimid, maybe you bring back Velcade and put it with Darzalex. So there's a lot of ways to kind of work with patients to get them well in that setting. And I think the majority of patients will get well in that setting. So. Right.
So, in fact, actually, maybe before we go on, maybe we could just ask, in the room here, how many patients have been dealing with their myeloma for 5 years or more, so that more in the longer disease category? All right, so really quite a significant number. How many are beyond 10 years at this point? Yeah. How many are beyond 10 years at this point right here? Yeah, there we go. Yeah, but...
Don't ask anybody their age, Brian, remember.
Huh?
Don't ask people their age, remember.
No.
Okay.
No. Anyway, questions?
Thank you. Right here.
Yes, this question is for Dr. Hoffman.
Okay.
I just recently experienced an extremely bad reaction to Pomalyst, and I was wondering if you've had any incidents with your patients having an extreme reaction to Pomalyst.
Can you describe, I mean, so we could talk more about the reaction, I suppose. I don't know how much you want to reveal, but Pomalyst and that class can cause a host of problems. I would say if someone's going to have an extreme reaction and need to stop it, it's often skin rash related. Okay, so that's what it was.
Yeah,
so
psoriasis.
Yes.
psoriasis over my entire body within
Yeah.
less than 2 weeks.
Yeah, so it's an extreme skin reaction to Pomalyst. It's a class effect with Rev and Pom. The majority of patients can be worked through rash with those agents. Yours seems to have been very extreme, and you get a little hesitant to kind of re-expose patients if they have a truly horrible rash. Usually by stopping the medicine, giving some antihistamines or even some steroids, restarting the medicine, maybe in a stuttering way, maybe every other day, or immediately dose reducing, you can kind of ease people through some of the skin reactions and ultimately allow them to be on it. It's really a shame to have to kick a good medicine to the curb until you really know you can't go back to it. So in an individual case, it's you and your doctor kind of evaluating how severe was the reaction, how important is Pomalyst, how many other options do I have, right? Those are some of the variables you got to work through. But for many that have bad rash to Rev or Pom, you can kind of navigate them through it and allow them to get whatever benefit they can get from that medicine. In the very extreme examples, if you have other alternatives, it may make sense to table it for a while, go to something else, and not close the door on revisiting, down the road.
Right. But unfortunately, occasionally you can have some pretty bad rashes, especially of the skin type. Yep.
At initial diagnosis, a patient is diagnosed with a specific clone. Can they have multiple clones? And we also hear that the myeloma you have today may not be the myeloma you have tomorrow. So can you have IgA kappa today and IgG lambda tomorrow? Or are the changes that you have from today to tomorrow different subtypes of the same clone?
Okay, so if we take the first thing, so that the more we've been studying the myeloma, and this has emerged in part because we've been focused on trying to cure myeloma, we've been focused on, well, is there this one clone that we need to get rid of? And the answer to that is that no, there's typically more than one clone. And on an average, this may seem a little bit crazy, but there's frequently like 5 subclones. So you have these multiple subclones, and so when you give that initial therapy, you get rid of, let's say you get rid of 4 of the subclones, and then you might have a little bit of one of them left. But it is part of that main clone, so that what's left is not usually like a switch from IgG to IgA, which is your second question. It's a part of what was there at the beginning, although it may not have been what we call the dominant clone. It may be just like a little bit that was there. And then, as you could imagine, when you give the treatment, you get rid of the clones which are sensitive to the treatment, right? And so the ones that's left is the one that is the most resistant to the therapy. And in our Black Swan project, for example, we're very, very interested to understand, well, what is it that's different about that little bit that's left, and how do we get rid of that other clone, right? The therapy to do that is one of the big focuses for the Black Swan project right now. So that's the broad picture. There's a lot more that could be said. What strikes you?
Yeah, just to take a different angle on it, I agree with, of course, with everything. The other component to what you're saying is on the medical side and the patient side, it can get confusing. Sometimes a relapse occurs, and like a class switch, as Dr. Durie mentioned, is very rare, but sometimes you are making a protein a lot in the beginning, and then your myeloma wakes up, but in a way where it's not making as much protein, or it doesn't make an intact antibody anymore. You don't see the IgG, for example, but you see the free kappa. And so it requires vigilance and expertise, certainly on the medical side, to make sure you're watching for a recurrence without just expecting it to be exactly like it was in the beginning.
Yeah, this is a very, very important point. Yeah. So, but this way of thinking about the myeloma is often helpful. It's not quite the same, and so we need vigilance. I like this word, vigilant. We need to be very careful in the more later relapse settings to be watching for anything that might be even a little bit new or different, but indicates the myeloma is active.
I had a late transplant without backup, and it only lasted 10 months. And then I was put on Darilex, Revlimid, and Dexamethasone.
Okay.
I always responded very well to Revlimid and Dexamethasone. I've had multiple myeloma for a long time,
Okay.
but now I'm not responding well. Can a bone marrow transplant really change the way you react to medications that you did well with before?
I don't believe so. I don't think we look at the impact of a transplant in that way. I think that just to go back to this last question that we're talking about, I think that the myeloma does tend to morph a little bit over time. And sometimes we're lucky, you know, where the same treatment will work well, you know, but then ultimately it may stop working. And this is more of the sort of thing that we see. And, but, you know, we could switch from Revlimid to Pomalyst, to pomalidomide. We have what we call this class identification, where if one of the IMiDs works, maybe one of the other ones, the Pomalyst would be a good backup to consider. And we were already talking about pomalidomide, Darzalex maybe could work, or Pomalyst with some other combo.
Okay, Alana?
Kyprolis Pomalyst, for example, is good. Okay.
Hi. I'm very fortunate. I'm on Darzalex and pomalidomide, and I've had great success now for almost 2 years.
Popular regimen around here.
Yeah. So I had a transplant that did not work, so I was very happy. However, when we were talking a while ago about the white counts and being and the getting sick, to infection. A year ago, I was here with Dr. Anderson, who recommended that I start getting Gammaglobulin like every 6 weeks. That has changed things significantly for me.
Okay.
In terms of my counts are still low, they're always low, but then they go right back up again. But in terms of me getting infections and staying healthy while being on treatment, that's had a huge impact. So I was just curious if you have any experience with this as well.
This is great. Yes, occasionally we tend to not use it so frequently. We reserve it for a situation where there's been recurrent infections, but sometimes it can make a dramatic difference, and I do have a number of patients who stay on that as a preventative, for long periods of time. As you possibly have discovered, it's not trivial, it's quite expensive, and you have to have a little quick chat with your insurance company to make sure that they will continue to cover it, right? But it can be remarkably effective, something we don't do so frequently.
Yeah, and I agree. I think we're seeing it more in my own practice with Darzalex. These patients have been pre-treated, and Darzalex is suppresses plasma cells, and we get a lot of what's called hypogammaglobulinemia, where the healthy antibodies are low. And that can come with kind of chronic respiratory sinus infections. We're even seeing, I believe, some diarrhea related to that. And both of those things can sometimes get better with the IVIG. We have some patients that get it just during the winter months, flu season, and then kind of get off of it over the summer. And so you can kind of, you can play around a little bit with that. And insurance is a big issue with IVIG. It's one of the bigger struggles I've had, actually, to kind of get it approved for patients I want to give it to. But we are using it more, I believe, in the Darzalex patients than I did before.
Well, it's good that you can get it covered. It is, each dosage is, the raw cost is several $1,000s. Yeah, so the insurance companies get kind of unhappy quickly.
We have one right.
But I'm glad it's working, okay? That's the main thing. All right.
Thank you for coming. We appreciate your time. Post-allo transplant, what are your thoughts on Zostavax and Shingrix for anti-shingles prevention?
Did you say post-allo transplant or post-stem, just stem cell transplant in general? Auto transplant? Auto.
You said say allo at the beginning.
No, I think
He
so.
did.
That's
I
what
think
I
he
did.
did.
But
Either.
You have to dock him 2 points.
So I think that it's very important to have shingles prophylaxis in myeloma in many different settings related to bortezomib, Velcade in that class for sure, Darzalex for sure. post-transplant. And acyclovir, for example, does a really good job preventing shingles, but we have questions now, right? We have had live vaccines have been available for a while, and those we really try to avoid in our patients. But as we're now entering a world where there are vaccines that are not live and there's no risk of infecting it, I think it's becoming a question, how effective are they going to be? All vaccines rely on your own immune system to a degree, and all myeloma patients have some immune deficiency, certainly at different points in their illness. I myself am going to be a late adopter, I think, of relying on that vaccine because acyclovir, if people take it, tends to be very well tolerated and the effectiveness is extremely high. So I think, I don't try to fix problems that don't exist. And I would be cautious to give someone such a vaccine, even if it's safe, which I believe the new ones are, and rely on it and say, don't take acyclovir.
So I agree completely. But my added comment is I don't like to give treatment that we don't understand. Since we don't understand exactly the defects in the immune system, I don't want to be pushing it in a certain direction without really understanding what's going on.
Okay. Oh, sorry.
No, just one final point. With regard to the allo part, I mean, the thing that comes up in the discussion there that we'll get into quite a bit tomorrow is the use of these CAR T cells, where you can actually try to replenish the activated T cells by actually giving T cells back to boost the immune system. And so that's a big thing that we're going to be talking about a lot more in the next few years, I'm sure.
Okay, right here.
Thank you, doctors. I've observed a spectrum of philosophies among myeloma doctor specialists. Some would suggest hit it hard, hit it early. Use the best available agents as soon as you can, early in the disease when it's most sensitive to treatments. And other doctors would say, hold off on these better treatments till later, save them till later. And I'm just wondering your thoughts on that and where would you fit in that spectrum?
Okay, so I'll go first on this. I don't know what Dr. Hoffman is going to say about this. So as part of this Black Swan project, we do have an initiative to hit hard early in the understanding that we think that this is the best way to achieve the best results. One reason that we're going in that direction, so what we're talking about specifically is to give Kyprolis, Revlimid and Dex, plus Dara, actually, the trial that we're going to be starting is that 4-drug combo. Darzalex added to Kyprolis, Revlimid and Dex. To give that early to patients with high-risk smoldering, and it's also something to give to patients with active myeloma. But the main thing I'd like to emphasize about that is that this is a pilot study. This is a study. It's a proof of concept. I mean, based on everything that we know, we think that hitting hard early is going to do a better job, but we absolutely need to prove that. The 2 parts of the proof are that you get your response, MRD negative hopefully, but you need to sustain it. And you need to have a regimen which is manageable for the patient so that it's not putting the patient at risk. So it needs to be a manageable, effective therapy that is really doing the job. And it's going to take us, 1, 3, 5 years to document what we're doing. Patients who get this MRD negative, a fantastic response, we need to show that it's going to last. And so in this situation where we don't know, you can certainly be open to the exact opposite, which might be to control the disease for as long as you can.
Yeah, so I would say, I agree. Philosophically, I definitely ascribe, on the scientific side, to the hit it early approach. I think that, if you kind of look at the science side, you would predict that that would be better long term. Now, the science has to apply to practical knowledge, and I would say that there was, or practical follow-up, and I would say there was a time where we had more toxic meds, and going from 2 to 3 to 4, the toxicity would really spike, and some of those trials were kind of failures. I mean, you didn't get a lot of bang for the buck, so to speak. I think the benefit now, and so to answer your question in a different way, when there was a question when it was Rev-Dex versus Velcade Rev-Dex, that your question came up, made a lot of sense. Well, do we hold the Velcade for later, or do we combine it? And in general, in myeloma, when the combinations have been tolerated, you get a higher response rate, more effective regimen, it translated to better results. And I think we're now in an era where the fourth drug is a monoclonal antibody, doesn't have really additive toxicities, so you'd expect, for example, this regimen of DARA-KRD to be well tolerated and to have extremely high response rates and MRD negative rates. And I think that's the way this is all going, and we're lucky we're at a place where these combinations involve immunotherapies and other, and not just chemical upon chemical, where the tolerability should be high.
Right. And ultimately, it may be that there are some patients where we can achieve cure, and the regimen is great. However, and like possibly in this room, there may be patients who can be controlled with their disease. The disease maybe never even goes into remission, and that can continue for 5, 10, 15 years, where in those cases, this control philosophy and saving for that future relapse works well. So it's not going to be one fits all either, I don't think.
Okay. Lana?
Hi. Can you hear me now? I have a question for you that's from a caregiver. And her question is, I think you kind of just touched on it, but what is in the pipeline for patients that have high-risk smoldering myeloma? They're right on the cusp of it becoming full-blown active myeloma.
Okay, well, similar to what I was just saying. So the first point I would like to emphasize is that when we talk about high-risk smoldering, what we're talking about are patients who are at high risk of going from smoldering to active myeloma. Their disease is not high risk. So it's not like we're talking about high-risk myeloma. Just as it was described here, we're talking about a patient who is kind of on the cusp of going from smoldering to active. Okay, so that's what that risk part means. But I think we should really have a better word. It's a little bit confusing when someone says, you're just diagnosed, and someone says, oh, well, you got high risk, and it's like, oh my God. But it's actually high-risk smoldering. But the platform or the options are pretty much all across the board. And so, for example, the Janssen company does have a study using just Darzalex to control high-risk smoldering. And so that is a protocol option. And then we, with the Black Swan, are just starting this Ascent trial, which is the complete opposite, which is Darzalex combined with Kyprolis, Rev, and Dex. I think that these are approaches which can be discussed individually, and it's a philosophic thing. You're going to have the philosophy of the doctor, and you're going to have the philosophy of the patient. The patient might say, well, I'm pretty happy with that Darzalex, it's controlling my disease, well, let's go with that. And then someone else might say, well, I want to really, knock this down, and so you need to see what strikes you as the best approach for you personally. And we can have those options because we don't really 100% know the answer.
Yeah, I think smoldering myeloma is a very hard, it's hard because it's not a one-size-fits-all at all. In fact, some patients that are smoldering will never have myeloma, and some are about to get myeloma. The average smoldering patient has like a 50-50 chance of needing some treatment within 5 years. So as you're sitting in front of a single patient, you don't know if it's like early myeloma or if it's really just an MGUS that has higher numbers associated with it. And I find it hard to, to funnel patients into a one-size-fits-all approach with smoldering. I think my own approach typically is to give people a lead time of a couple of months of close follow-up to see if you can gauge whether the trajectory is an upward one or a stable one. Those that have these higher risk smoldering conditions with rising numbers regularly are often destined to need some treatment soon, and then could maybe go the route of such a trial or early treatment, whereas those are really stable. Sometimes you get lucky and keep them off all these meds for somewhat of an extended period of time. So I think that the advances in smoldering, I hope, will come in better predicting who's in which category, more so than in some treatment for smoldering.
Right. Fully agree. I think that high-risk smoldering as a category, it would be actually good if we just got rid of that name. I would prefer it. And then just talk about treating myeloma, where we have some security that the disease is moving into myeloma and we're just going to treat it early. And I would be a lot happier with that. And we've already kind of done that, where we've moved from just the CRAB criteria, where we actually now are treating myeloma patients a little bit earlier. you know, if the percentage plasma cells is high, if the free light is above 100, and if they have, you know, more than one lesion on an MRI. So we've kind of moved in that direction where we have a clear indication of an early myeloma, and I think that might be ultimately the smarter way to go.
All right, Jonathan.
Thank you. Right over here to your right.
Hi, Dr. Hoffman. Good to see you again. With regard to monoclonal antibodies and Darzalex, as my understanding, it attacks the CD38 protein on the surface of the myeloma cell. Then I just recently, thanks to a friend, learned that there's research being done on a CD48. So the question is, how many of these CD proteins are there, if you know, and are people actively engaged in trying to, I mean, it means there might be another 46 targets out there that would be the basis of another therapeutic treatment.
So there's a lot of them. There's a lot of them. CD48, I think that might be one that's linked to 1Q plus, actually. Anyway, there are plenty of these, and the question is whether attacking them is sufficient to shut down the myeloma. And so this is something that we learn about over time. So the CD38, that's something that we've known about for 20, 30 years, actually. And so ultimately, we were able to have an antibody that was selective and can shut down the myeloma without too much side effects on other cells that might have that same marker. And so there is quite a bit of potential to look at, and we already know a number of them, where there are markers on the surface of the cell. So for example, we don't usually use the CD numbers, so we use this other monoclonal, which is elotuzumab, which is attacking like the NK markers. So that's also present on the surface of the cell. So there are a lot of them. It just takes time to learn how to take advantage of them.
Yeah.
Okay, Kelly?
I would like to know, based on what we were talking about with respect to the Shingrix and other vaccines, are you aware of what allergy shots, general allergy shots could possibly do to our immune system? And I'm looking particularly in low risk or intermediate risk smoldering myeloma. It seems like the question comes up pretty often for those of us that have been on allergy shots or immunotherapy in that respect for a long time. Is there any possible downside with respect to challenging the immune system? Because I know the difference between IgE, IgG. Hello, Dr. Hoffman.
Okay, you can fill me in on this.
I think I should warn Dr. Durie that some of my most informed patients are in this room.
Yes.
And
Don't give it
they're
away.
coming at us with the good, with the
good
tough
questions, yes.
Well,
sorry.
Yeah, so you possibly know then that, I mean, there has been a long-standing question about myeloma. Is chronic stimulation of the immune system a trigger factor? And so the question would be, if you've been on allergy shots for a long time, has that been a contributing factor?
Yeah, I think that, there's this idea that provocations of the immune system, ultimately may lead or partially lead to the development of these clones, and whether it's exposure, some of which have been clearly shown to increase the risk of myeloma. Most patients don't have those exposures. Whether they're inflammation related to obesity, and there's a whole bunch of different things. And I guess I put that kind of thing in the category of theoretically possible. And so what do you do then? Well, you kind of have to weigh some things out. You weigh how important are my allergy shots? And if something is not important, you try to eliminate it. I try to eliminate everything that my patients are doing that may be harmful unless they really need it for some other reason. I wouldn't put that in the high-risk category. If your allergist says you really need it or you're going to have big problems, I think it's okay. But if something's not needed and it is provoking the immune system, right, you could try to remove it from the equation.
So a couple of points. I think that it's helpful to correlate the timing. In other words, if there were a lot of allergy shots and then the myeloma happened to change, you might be able to make a linkage in a particular case, and then, I would look at it more cautiously. But There is a good example where we know that obesity, being overweight, can increase some risks related to myeloma. And so the question is, what is the risk? And so the first way of thinking about the risk is that if obesity caused myeloma, there would be a myeloma epidemic in America, right? Which there is not, right? So I don't think obesity is causing myeloma. However, what has been shown is that if you do have increase in fat cells, you can get some microenvironment, like little growth factors, and it may be that it enhances maybe the growth potential, or maybe has some negative impacts on the aggressiveness of the myeloma. And so it's something to look at. These are just factors to consider.
Okay, we're down to the speed round now, okay?
Okay.
Right here, Felice.
Okay. I was on Revlimid initially, and it created some skin problems, so we went off of that. And now I'm on the Velcade and developed the psoriasis. Is the psoriasis then connected with the disease itself? Because I heard you say something about that earlier. I'm just wondering if it's really
Psoriasis?
connected.
Not as far as I know.
I mean, you can get skin reactions to Velcade. You know, sometimes people get real. Are you getting it under the skin or in the vein, the Velcade? Is it being put in the belly?
In the vein.
In the vein.
The under the skin created skin problems.
Yeah. I don't know. I mean, yeah. I think that the predisposition to skin issues, it's in part drug-related, but it's also related to the individual. So in fact, I think this gentleman over here who had a very bad skin reaction with Pomalyst also had a very severe reaction with Cytoxan, I think, if I'm not, is that correct? No, not Cytoxan. Anyway, you can, you can get reactions with a variety of things. You're predisposed separately from the drug.
And the other thing, too, if I may,
Yeah.
sir, the other thing is that you just mentioned something about obesity.
Yes.
I used to be over 250 pounds, and that was 25 years ago. Could that have, because when I went to the doctor, he said, you probably had this for 20 years. So could that have promoted the cancer?
Well, that's the aspect where there's a question. As I was joking about it, I'm sure it doesn't cause myeloma, but it can be a negative factor possibly, yes. That's what we're looking at. And not just for myeloma, for all kinds of cancer.
Thank you. Susie, and my wife and I have been here for 3 years in a row now, and we want to thank the group, the foundation, the doctors. This is just every year, it's just so enlightening, and we want to thank you. The question is, can you just be a little more specific? We understand what MRD negative is, but related to remission, and at some point, people who are being treated and are in remission, are they tested for so-called MRD negative?
Not routinely, just to answer the first part first. I mean, right now, I don't think we're routinely checking for MRD. So right now we do testing for what we call this complete response and stringent complete response, which is based upon the amount of the protein, the regular myeloma protein in the blood and the urine. And then in the bone marrow, we just look under the microscope and see if we can find the myeloma. And so we use that kind of testing. What we found is that if you look in the bone marrow using more precise testing, either molecular or by a flow cytometer, you can pick up even smaller numbers of cells, like 1 in a million. And so with that higher sensitivity, we know that that can give us better precision to predict the length of your remission and your survival. So if you take a person who's in a complete remission, a regular complete remission, what we know is that 50% of patients who are in a complete remission are MRD negative, but 50%, when you look more closely, you do find a little bit of myeloma, so they're MRD positive. So there's a split there. And we know that if it's MRD negative, it's better. Now, the big question, and the reason that we don't do it routinely across the board, is well, what are we going to do about that? You know, it's good to know, but we don't have an automatic thing. So if you're on maintenance, for example, and then we do it and you're MRD negative, are we happy and we'll say, oh, well, we can stop your maintenance? Well, we're not so sure about that.
Yeah, I think, yeah, so one other thing, it involves another bone marrow. So, you know, so the issue is if someone comes out of transplant and they're in a complete remission, like you said, if you divide those that are MRD negative and MRD positive, there's a prognostic importance there, but at the moment there's no reaction to it. So what's all the excitement about MRD? Well, I would say scientifically speaking, again, if you're running a trial, if we're trying to cure some people with myeloma, we know the cures are going to be in that MRD negative cluster. And I would say another almost problem, but it's a good problem that we have in myeloma in conducting trials now. So if you have a really terrible disease and you want to conduct a trial, you give half the people this and half the people that, and in a year or two you know which one was better because it's such a terrible disease, people struggle very quickly. Thankfully in myeloma world, people in the room here more than 10 years, et cetera, we think that's only getting better. So if you want to try A versus B, it's going to take you a really, really long time, thankfully, to know how well people do. So using markers like how deep can you get the remission becomes a surrogate for that we look at. So on almost every clinical trial that we're doing now, MRD is included, so we can see, well, how low are we really going? And this way you can compare A and B, both in terms of remission and even more based on MRD. So on the trials, we're definitely using it.
Key point. One piece of good news coming up, just mark these words. The words are mass spec. So it's mass spectrometry. And this is a blood test that will allow us to measure the amount of the protein, the myeloma protein in the blood and the urine in a much, much more sensitive way. And so it's possible that without repeating those bone marrows, we could have the ability to check more closely in the blood and urine and have a similar type of information. So this is a
Okay,
good
Dr.
thing.
Durie, that's very interesting. We have 5 minutes.
All
John.
right.
Okay.
Very harsh,
Right.
very harsh.
Thank you. Thank you. Right here in the back, in the middle.
Hi. This is a follow-up question. I'm coming out of 4 years of remission, and I'm looking for some clarity on what the key factors are in determining what my next treatment might be.
Okay. So you're in remission for 4 years?
I've been in remission for 4 years and starting to gradually come out, as we discussed earlier. And I'm interested in what the key considerations, factors would be in determining what next treatment I would be going into.
Right. And so you're not on any maintenance, though?
No maintenance.
Right.
And I had a bone marrow transplant 4 years ago. And VRD was the initial treatment.
Right.
Yeah. So there's a lot of good choices. I think that's the most important thing. I mean, some of the variables are previous treatment, current treatment, how well or sick is somebody at the moment, how well are their kidneys, how well are their liver. The molecular features of the myeloma can sometimes have some impact, but given your specific example, your disease stayed quiet nice and long after induction transplant with no maintenance. So you could simply go back to what worked so well back in the day. That would be one option. You could do that, with some variation, right? Instead of the Velcade, maybe you go to the newer Velcade. I mean, so there's so many choices, which is really good. If you did great with VRD in terms of how you felt when you were on it, there's certainly no harm in going back to that. And if you induce another remission, maybe this time coasting on some maintenance.
Right.
But again, I don't think there's one answer for you. There's hopefully a lot of answers that'll give you a good result.
Yeah, a lot of good options. So Revlimid, VRD, or now there could be a transition over to Ixazomib RD to bring it back in remission and sustain it. A lot of good choices there.
Okay, good. Kelly, and this is our last question for this session. Remember, you're here for the weekend, so don't worry about it.
So.
Yes, I just have a very quick question.
So if you just speak up, yes.
Yes, I am on Revlimid 10 milligrams every other day.
All right.
And what I notice that I get quite frequently is chest pain.
So you're taking Revlimid 10 milligrams every other day, like continuous, is that right?
Yes.
Okay.
Yes. And I get really bad chest pains. It's just really scared the daylight out of me.
I'm just having a lot of
You're
pain.
getting chest pains all the time?
Chest pains, yes.
Uh-huh.
Well, maybe one caveat that chest pain can be an emergency, and so there's times where chest pain warrants an immediate evaluation, but if it's a chronic on and off
Yeah.
issue, it's not a common feature of Revlimid. Revlimid can certainly cause muscular cramping sometimes. I try to simplify things, and what I generally do if I'm not sure if it's a medication effect is take a hiatus from the medication. Hold the Revlimid for 2 or 3 weeks, and we've already tried that.
What I did though, when I was concerned, I had a stress test done, very thorough stress test, and it had nothing to do with the heart or anything like that.
She had a stress test and it wasn't a cardiac issue, so.
Okay. Well, I think the stopping the Revlimid for a short time is probably something that could be done safely, and just to see how the pains change. I think it's very, very important to find out if it's because of the Revlimid. And this is a little bit unusual schedule. I have seen some little bit different toxicities where you take it continuously without the 1-week break. And so I think that would be the first step. And then if you're still having the chest pains, then you probably need to go beyond the stress test to some more detailed cardiac testing, probably.
Yeah. And sometimes even gastrointestinal issues can cause some pain, spasm of the esophagus or reflux. And in terms of that every other day schedule, I sometimes use it, but I also always give people, like Dr. Durie said, the week off. I think that helps. Sometimes that every other day schedule helps with copays a little bit too, where you can get the whole month's supply and it lasts you for longer. So I've done that for some people that have excessive or high copays. But
Good trick.
Yeah, but the week off is a good idea, and maybe a GI evaluation if it doesn't get better without the Revlimid.
Right, right.
Thank you.
Broadly, this does indicate something that's quite important as myeloma patients are living longer and doing better, is to have a good internist who is following up on some of these things. Is it a heart issue? Is it an esophagus issue? What is causing this? And have someone who really is not busy seeing other patients in the hem-onc clinic, but is focused on the medical aspect.
Well, gentlemen, big round of applause. They did
All
great.
right.